हेलो।
हेलो।
हाँ जी पापा।
उठ गए क्या?
हाँ पापा, मेरा यूट्यूब सेशन चल रहा है, मैं अभी करता हूँ आपको।
ठीक ठीक।
Okay guys, very good morning. I think I can see you and I can't. I hope you are hearing me. I am audible. I can't see you, but I can feel your energy and you are prepared well. Now, nothing to worry. Just be focused. Gather your knowledge at one place and hit properly. I thought before your exam, I will bring this psychiatry YouTube session, and in 5 sessions, I will try to cover maximum psychiatry important point from various topics. Okay, so I hope you are ready. Just give me one at least one signal that okay, you are able to hear me and no issue. Write down on chat box, please. Okay, so today I promise that we'll go for neurocognitive disorders. So before we were calling it yeah, yes sir. Okay dear. So neurocognitive disorder, previously we were calling it a organic disorder. We'll talk about dementia. Every time one or two MCQ they are asking about dementia. So what are important points you should know about the dementia? Very good morning. Decrease level of acetylcholine or choline acetyl transferase. Increase level of glutamate, and decrease level of norepinephrine. Acetylcholine decreases in nucleus basalis of Maynard. This is they can ask about the biochemical theory. So acetylcholine decreases, or which enzyme decreases? Choline acetyl transferase. Glutamate increases, norepinephrine decreases. Acetylcholine decreases in nucleus basalis of Maynard. Definitely they are going to ask about the genetics. In genetics, guys, two things. We have a late onset familial dementia and early onset familial dementia. Before we were calling it a senile or pre-senile. These are outdated terms now. In late onset, two genes you have to remember: ApoE gene and ubiquitin. ApoE gene is chromosome 19, ubiquitin is chromosome 9. Second, we have early onset familial dementia, amyloid precursor protein. Presenilin 1 and presenilin 2. Amyloid precursor protein 21, presenilin 1 14, presenilin 2 1. That they can ask you. So ApoE gene, ubiquitin 9 and 19 late onset familial dementia, amyloid precursor protein, presenilin 1, presenilin 2, chromosome 1 14 and 21 early onset familial dementia. ApoE gene, responsible for cholesterol metabolism. Ubiquitin is responsible for protein degradation. protein degradation. When we have a problem, then we have this neurodegenerative changes. Okay. Another important point, that there is no impairment of consciousness. No impairment of consciousness. Dementia is a organic disorder, neurocognitive disorder. Despite that, we don't have any impairment of, because one of the characteristic of organic or neurocognitive disorder is what? Impairment of consciousness. Dementia is a neurocognitive disorder. Despite that, there is no impairment of consciousness. Regarding diagnosis, they will ask you, what is dementia? It's a impairment of higher mental function. It's a impairment of higher mental function. Please listen carefully. Every point we'll discuss here, and in exam easily you will able to do it. So every time, even this INSCT recent exam was there, they asked one question, all of the following are subcortical dementia except. So these questions they are asking. So impairment of higher mental functions is a dementia. It is not just memory loss or forgetfulness. Okay. In this memory, one MCQ they are asking, another higher mental function, no need to discuss, but in memory they are asking nowadays. So you should know. What you should know, we have a 3 type of memory. This is a simple classification: immediate memory, recent memory, and remote memory. Up to 3 to 5 minutes immediate, up to 1 week recent, and more than 1 week is remote. Immediate and recent memory storage in hippocampus, remote memory storage in a neocortex. Okay, immediate, recent, and remote memory, that you know already we discussed in classes as well. The second classification I want to tell you about memory is, we have declarative or explicit memory. Declarative or explicit memory, or non-declarative implicit memory. Declarative or explicit memory, non-declarative or implicit memory. Declarative, which we can express; non-declarative, which we can't express. We can show through our skills. We have a 2 type of declarative memory: episodic and semantic. Episodic is about personal experience. Semantic is about facts, about general knowledge, about fact or general knowledge. Okay. Episodic memory, we have deficit in amnestic syndrome. Semantic memory deficit we have in a Alzheimer disease, particularly frontotemporal dementia. So semantic memory deficit, just remember for exam point of view, we have in Alzheimer disease and frontotemporal dementia. Episodic memory deficit we have in a amnestic syndrome. It is about personal experience. Semantic memory is about facts or knowledge, the object, people, general knowledge. Okay. Declarative memory, non-declarative memory we have in a the types of implicit or non-declarative memory. The non-declarative memory is types. We have procedural memory, we have conditioning, we have priming, okay, and we have habituation. We have habituation. So this is procedural, conditioning, priming, habituation. Procedural memory is about skill. Deficit occur in subcortical dementia. Subcortical dementia. It's about skill. Okay. Conditioning. We have, classical and operant. Who has given the classical conditioning? Pavlov, and operant conditioning, Skinner. So procedural memory is about skills, how to play badminton, how to play cricket. Deficit occur in a subcortical dementia. Conditioning, we have a classical conditioning given by Pavlov, operant conditioning given by Skinner. Priming, we have one stimulus. One stimulus actually helps in telling the subsequent stimulus. So one stimulus, one idea will be given to you, and this stimulus actually helps in telling the subsequent stimulus, priming, and we have a habituation. The same thing happening. Suppose one teacher is scolding you every day. Initially you will feel bad about it, but later on you will get, okay, whether I am doing good or whether I am doing bad, he is doing the same thing. So it's a kind of habituation. So this is a non-declarative memory. These MCQs they are asking. So we have one is simple classification of memory: immediate up to 3 to 5 minutes, recent up to 7 days or 1 week, and the remote is more than 1 week. Then the second classification, we have a declarative explicit, non-declarative implicit. The declarative, we have a episodic, deficit in amnestic syndrome, about personal experience. Semantic is about facts, general knowledge. We have deficit in Alzheimer disease, more particularly frontotemporal dementia. Non-declarative, we have a procedural, we have a conditioning, we have a priming, we have a habituation. Okay, priming question also recently they have asked, so be very careful about it. Procedural is deficit occur in a subcortical dementia. It's about skills, and conditioning we have discussed many times. Okay guys, this is the about memory. Then they can ask you that we have this apraxia, agnosia, aphasia or dysphasia, and acalculia. These are the another higher mental function. Apraxia, impairment, inability to carry out motor activities despite motor system is intact. Agnosia is inability to recognize object despite sensory system is impaired. Aphasia or dysphasia is what? Person is having a language disturbance. And we have a dysarthria, another higher mental function. What is the difference between dysarthria and aphasia or dysphasia? Aphasia, person is having a language disturbance. He is not able to, remember the name of the relatives, day-to-day activities. So patient forgets. In dysarthria, patient doesn't forget, but he is not able to pronounce the thing. He is not able to, articulate the name of the things. This is dysarthria. And acalculia, difficulty in calculation. So these are the important higher mental functions. We have impairment in dementia. Despite being an organic disorder, dementia, there is no impairment of consciousness. Okay. They ask the guys about types of dementia, again and again asked, and they can ask in your exam also. So remember by heart, we have a cortical dementia, we have a subcortical dementia, and we have a mixed dementia. Cortical, subcortical, and mixed. Cortical, we have a what? Alzheimer disease. Okay, yeah, Dr. Gulam is liking it. Thank you so much, dear. So Alzheimer disease, we have a Pick disease, and we have frontotemporal dementia, and we have Creutzfeldt-Jakob disease. So Alzheimer disease, Pick disease, frontotemporal dementia, Creutzfeldt-Jakob disease. Fatafat. Another name of Pick disease is what? Frontal lobe syndrome. Alzheimer disease is the most common type of dementia. Roughly 50% patient only suffer from what? Alzheimer disease. For 50% patient. Creutzfeldt-Jakob disease is what? It's a guys very rapid progressive dementia. So fastest progressive dementia is a what? Alzheimer, the Creutzfeldt-Jakob disease. So 3 points here. Number 1, Alzheimer disease, most common. Another name of Pick disease is a frontal lobe syndrome, and the fastest progressive dementia or very rapid progressive dementia is Creutzfeldt-Jakob disease. Very true, Dr. Krish. It's an example of prion disease. It's an example of prion disease. Excellent, guys. Subcortical dementia, the examples are the Parkinson disease. Now I am writing in a short form. You are very intelligent now, so you don't have a problem. So Parkinson disease, Huntington's chorea, we have Wilson disease, we have multiple sclerosis. Please remember, HIV dementia is an example of subcortical dementia, normal pressure hydrocephalus, and we have a supranuclear palsy. So Parkinson, Huntington's, Wilson, multiple sclerosis, HIV, and PH, supranuclear palsy. These are the example of subcortical dementia. Mixed dementia is, vascular. We have a Lewy body dementia, and we have a neurosyphilis. We have a neurosyphilis. Okay, neurosyphilis. Second most common type of dementia is a vascular dementia. So most common type is Alzheimer disease. Second most common type is a vascular dementia. Alpha-synuclein make the Lewy body in Lewy body dementia. So Lewy bodies are made up by alpha-synuclein in Lewy body dementia. Cortical, subcortical, and mixed dementia. Okay, if they ask you in pathology, you have to remember that we have macropathology and we have micropathology. In macropathology, we do the CT scan. In CT scan, guys, we have diffuse cerebral atrophy. We have diffuse cerebral atrophy, Okay, there is atrophy of gyrus, widening of sulci, and enlargement of third and fourth ventricle. Enlargement of third and fourth ventricles. So, diffuse cerebral atrophy, widening of sulci, atrophy of gyrus, enlargement of third and fourth ventricle. In micropathology, we have beta amyloid plaque, and we have neurofibrillary tangles. Beta amyloid plaque made up by beta plated sheets. Neurofibrillary tangle are made up by tau protein. Beta amyloid plaque is an extra cellular finding, and neurofibrillary tangle is a intracellular finding. Both are non-specific finding. These findings can be part of other disease as well. Okay, yeah. If they ask that which is more specific, then your answer will be beta amyloid plaque is more specific than neurofibrillary tangle. Beta amyloid plaque is more specific than neurofibrillary tangle. Okay, guys. Beta amyloid plaque might correlate with cognitive impairment. Neurofibrillary tangle correlates with dementia severity and duration. That point you have to remember. So beta amyloid plaque might correlate with cognitive impairment. Neurofibrillary tangles correlate with dementia severity and duration. Okay? Yeah. Done? We do the mini mental state examination. It's a mini mental state examination. In this we have it's a screening test. What we screen? We assess the cognitive function. What we assess? Cognitive function. We assess the cognitive function. It's a maximum score is 30. We have a score 25 or more, 21 to 24, 10 to 20, and less than 10. It's normal, no cognitive dysfunction, 25 or more, 21 to 24 is mild dementia, 10 to 20 moderate dementia, and less than 10 severe dementia. Okay, severe dementia. What areas we assess in MMSE? That they can ask you. So in MMSE we assess the area are orientation, immediate registration and recall, okay, attention and concentration, and language and language. We have 10 number of orientation, 3 number of immediate registration and recall, 5 number is attention and concentration, and 9 number is language. So maximum we have number for orientation, guys. This is a very important MCQ they can ask. Okay, so orientation, immediate registration and recall, attention and concentration, and language. Mini mental state examination, another area they can ask here. Apart from that, we have Hirano bodies, that also we have in a Alzheimer disease. That MCQ can be asked. Alzheimer disease. Okay. Apart from that, if you go in a treatment you can go through. Just remember, we have donepezil, most preferred drug in dementia, acetylcholinesterase inhibitor, tecrine we don't use because it's a hepatotoxic. Okay, and we have vinpocetine. Vinpocetine is a drug, phosphodiesterase 1 inhibitor we use in Alzheimer disease and Parkinson disease both. Alzheimer disease and Parkinson induced dementia both. Okay, briefly, if they ask you about the delirium, again and again they ask about delirium. It's a most common organic disorder. Okay, most common. Criteria, impairment or clouding of consciousness, disorientation to time, place and person, immediate and recent memory deficit, remote memory remain intact. Thank you so much, Dr. Gulam. I am here for you guys. I always have done it and continuously will do till the time I will teach. So immediate and recent memory is for, deficit is there, remote memory remain intact. We have, if the examiner asks you which type of delusions you have in a delirium, transient or fragmentary delusion, we are in a transient or fragments. In class I everything explained you why it is so, but now this is not the time. Just go for transient and fragmentary delusion. And we have a sundowning phenomenon seen in delirium patient. What is sundowning phenomena? As the evening comes, as the sun sets, as the sundown, patient condition get worsened. This is a sundowning phenomena. Just remember, seen in delirium. Okay, we have visual hallucinations, we have illusions. Criteria you have gone through. Just remember that confusion assessment scale we use to assess the delirium. This is a very important question. Assess the delirium. Okay, and then we have about delirium. The treatment of delirium, very important. Point number 1, benzodiazepines are contraindicated, because they cause the cognitive deficit except to delirium. So benzodiazepines are contraindicated except, already we have discussed in classes, alcohol withdrawal delirium and benzodiazepine withdrawal delirium. Okay, in both we give long acting benzodiazepines. So drug of choice in both these delirium is a long acting benzodiazepines is what? Diazepam and what? Chlordiazepoxide. Diazepam and chlordiazepoxide is a drug of choice in these two delirium. Otherwise, guys, benzodiazepines are contraindicated in delirium because delirium is a cognitive, it's an organic disorder, and benzodiazepines, they cause the cognitive deficit. Then what's the treatment of delirium? The treatment of delirium is treat the etiology, treat the cause or treat the etiology. Whatever the etiology, serum electrolyte imbalance, renal problem, cardiac problem, you treat the cause. Okay, and we give the low dose of haloperidol. Low dose of haloperidol. Yes, Dr. Krish, if you not treat the delirium is a lethal condition. Patient can, lose his life. So delirium, it's one of the lethal condition in psychiatry. Be very careful. You have to treat the delirium is very, very properly. Even you treat the delirium, properly, the mortality is there in delirium. So without treatment, you can, guess or you can imagine how much mortality is there. So it's a lethal condition. It's an emergency condition. You have to handle it in an emergency way. Low dose of haloperidol we give to decrease psychomotor activity. One question they can ask you about the Wernicke's encephalopathy. In Wernicke's encephalopathy, guys, it's a vitamin B1 deficiency. Because of that, enzymes are not able to work properly. Because of that, we have a what? We have a lesion in what? Mammillary body and dorsomedial nucleus of thalamus. Mammillary body and dorsomedial nucleus of thalamus. Okay, and because of that, we have three symptoms. What symptoms? GOA, global confusion, ophthalmoplasia, and what? Ataxia. Ophthalmoplasia and ataxia. So remember one thing, ophthalmoplasia we have due to what? 6th nerve palsy, and there is a what? Bilateral lateral rectus palsy. So delirium also a part of Wernicke's encephalopathy. So whenever they will ask you Wernicke's encephalopathy and delirium, be very careful. Suppose this is a delirium and this is a Wernicke's encephalopathy. In delirium, we never have a symptom like a nystagmus or ophthalmoplasia. So if examiner gives you the delirium along with ophthalmoplasia, always diagnosis is what? Wernicke's encephalopathy. So in simple delirium, we never have the ophthalmoplasia or nystagmus, these kind of symptoms. If they ask you treatment, initially you will give what? You will give thiamine, roughly 1000 gram bolus, and then you give glucose. You never give glucose first because patient condition can worsen. Okay, and first symptom, if they ask which will respond to treatment, answer is what? It is ophthalmoplasia. Ophthalmoplasia is respond very frequent, within hours. Okay, within hours. If you will not treat this patient properly, then they will convert into what? They convert into Korsakoff psychosis. We have done, I hope you read about Korsakoff psychosis. 1-2 important point I want to tell you about Korsakoff psychosis. It's a more severe condition. Lesion is same like in Wernicke's encephalopathy, the mammillary body lesion and dorsomedial nucleus of thalamus. Only thing you have to remember about Korsakoff, that it is not reversible. It is reversible condition. It's a reversible condition. One option sometimes they give that it's a irreversible condition. No, it's a reversible. How much reversible? That depend on a severity of the patient. Maybe it's a partial, it's a 20-30%, but it is not completely irreversible condition, guys. And because of confabulation because of memory deficit. What is confabulation? Because in Korsakoff psychosis we have memory deficit, but it's a psychosis. Insight is absent. Patient forgets the thing, but patient also forgets that he forgets. Patient भूल जाता है, लेकिन वो ये भी भूल जाता है कि वो भूल जाता है. Patient forgets about past, but he also forgets that he forgets. So this is confabulation. Filling up memory gaps by false memory. Filling up memory gaps by false memory. And please remember that in Korsakoff psychosis we have the anterograde amnesia is more than retrograde amnesia. So it's a anterograde amnesia more than retro. So most of the condition we have retrograde more than anterograde. It's one of the rare condition where anterograde more than retrograde, and treatment is what? Vitamins. Treatment is vitamins. So guys, we covered today dementia, delirium, Wernicke's encephalopathy, Korsakoff psychosis, total neurocognitive disorder. The important point I have given you. I hope you like this class. The same session, that kind of session we will have every day, continuous 5 days. So please tell your friends and share this link more and more. I want that the students should get benefit out of it, and I hope you like this session. Yes or no? And tomorrow I will bring the new session. The important points, what I think that recent in exam they have asked, what they are targeting, hot topics. So I think after this session, if you will go to your exam, you will not have any problem in psychiatry. See, this INACT also has been, that recently we had, the 1 week before this exam, and that many things they can ask, but they can't, turn so much the minor subjects. See, 10 questions have been asked in INACT from psychiatry, and all direct questions were there. Nothing, if and buts, no image, nothing. So these, subjects are really productive subjects. They are, don't miss these subjects. Okay, so be there in psychiatry. And I'm one more thing I want to tell your friends also. Biochem session also I'm bringing this special class, 25th, 26th and 27th, 3 hours biochem sessions, and I will cover the important point of biochemistry as well. Okay guys, thank you so much. Have a great day. Just hit properly with the enthusiasm. Don't think about exam. As a faculty, I'm telling you that even lengthy questions are there. It is beneficial if you are really prepared well, because something you will get from the hint from the MCQ itself. When one liner is there, either you know or you don't know. But if you are prepared well, and if the lengthy question is there will be hint of the answer. Okay, so don't worry about that. Yes, you should worry about one thing, is time management and how to connect with the MCQ. Okay, so in subsequent session also we'll talk about that. I hope you enjoyed it. Love you guys. Have a great day. See you tomorrow morning 8:35. Bye bye. God bless.